Hi, my name's Julian, and today I'm going to spend a little bit of time talking about facial trauma. If you're not too confident with facial anatomy, I suggest you just take a brief look at my previous talk titled Normal Facial Anatomy. Okay, so let's imagine that we have somebody who presents to the department like this. We know that the face is a very complex structure. It can sustain multiple different types of injuries, and it often does have multiple different injuries at the same time when people present with this sort of thing. So we really want to be able to have an approach to help us delineate how to deal with these sorts of patients. Okay, so the first thing is history. Providing that the patient isn't in need of an airway or isn't in extremis, we can take a bit of a history to begin with. There are some specific questions that are unique to facial trauma that you want to bear in mind. First one, can you breathe through both nostrils? If the answer is no, perhaps they just have a blocked nose, or perhaps they do have a nasal fracture. Are they having trouble speaking? This may be due to a kind of locked jaw because of trismus, and that may be secondary to, for example, a mandibular fracture. Is there any double vision or visual disturbance? There may be damage to the eye itself, or a blowout fracture with tethering of the inferior rectus muscle. Is there any facial numbness anywhere? The infraorbital nerve can frequently be damaged because it exits through the maxilla anteriorly, and that may result in lateral nose reduction in sensation, or underneath the eye reduction in sensation, that sort of area. Do your teeth come together normally? If not, maybe there's a fracture of the mandible. And similarly, are there any loose or painful teeth that may indicate dental trauma? So the next thing that we do need to do is remember to try and figure out the why. How come they've got this facial trauma? Is it an elderly person who's fallen? Don't just ignore the fact they've fallen, because it's so easy to get wrapped up in trying to deal with the face. We need to know why have they fallen after taking care of all the facial injuries. Think about your normal kind of workup. Is it cardiac syncope? Do they need ECGs? Do they need lying standing blood pressures, etc., etc.? Seizures, RTAs and assaults. Just explore the underlying culprit and make sure you document very clearly, because if it's something like an assault, there may be in the future need to review your notes for litigation or criminal prosecution purposes. So that's just a bit about the history. Now the exam. So facial trauma can be absolutely horrendous, and when it is, you're going to be spending a lot of time in this part of the management. You're going to want to do a proper A to E assessment, and you may have someone who presents with a huge amount of hemorrhage. For example, in a self-inflicted shotgun wound injury, there may almost be no face at all. Even finding an airway and trying to intubate somebody in that sort of scenario will prove extremely challenging. So it's just to say that these can be really extreme at the far ends of the presentations of facial trauma. Try and consider whether there's any intracranial injury, any cervical injury. If there's been enough force to cause a facial trauma, these two areas can also be involved. Take a note of the GCS, document the conscious level. If this person's presenting with a GCS less than 15, they may need a CT scan in the context of head or face trauma. So that's just a bit to say about there. Now we're moving on to sort of the bread and butter of the exam. So we're going to look at the soft tissues and the bones of the face. This is sort of a look, feel, move approach, if you will. And we're going to start with inspection. You're just going to check, are there any asymmetries or any contusions, hemorrhages, swellings, such as in this chap here. We can see that he's got a nasty contusion here, some lacerations, asymmetry of the jaw down here. These could be indicating a number of different problems. You could have a fracture of the mandible. It could even be dislocated. Just take the time to look properly at somebody's face. You're actually also going to palpate the face. Check for any step-offs. Palpate along the bony margins, the anatomical landmarks that you're already aware of from our previous talk. See if there's any emphysema from disruption of any of the paranasal sinuses. Tenderness itself may be indicative of a fracture. And abnormal motion is something to bear in mind. If you're checking for a lefort fracture or a fracture of the midface, stabilizing the top of a person's head and gently pulling back and forth on their upper incisors. If there's any movement of the face, they may have a floating palate, a floating maxilla, or at worst, a floating face. You're also going to consider exploration of any open wounds, adequately anesthetize and wash out any areas and check there's no foreign bodies, if there's anything like a big laceration anywhere. And after you've done all that, you're going to make sure that you do a decent neurological exam of the structures of the face too. And of course, the eyeballs are within the face, and you need to do a good ocular exam. This involves checking visual acuity, the visual fields, the pupillary light reflexes, a bit of a examination of the anterior chamber of the eye, and check the extraocular muscles. Do all the different movements of the eye as well. Sensation, your trigeminal nerve as per your ophthalmic, maxillary and mandibular branches. Do a motor exam, essentially examination of the facial nerve that you would do in any normal cranial nerve exam. And then also consider this special test down here, the tongue depressor test, if you've got any concern of mandibular injury. This is a great rule-out test for any mandibular fracture, and basically just involves inserting a tongue depressor into someone's mouth, asking them to clamp down and to twist it, and if they can hold onto it while you snap it, then that pretty much rules out a mandibular fracture with a sensitivity of 95% and also a decent specificity of around 65%. So that's the general approach to a facial injury. Next bit we're going to address is imaging. So the first question is, how significant was the trauma? If it was a high impact, high force trauma involving a road traffic accident or a really nasty assault, something like that, discuss it with somebody, because you're probably going to end up doing a CT scan and just bunny hopping straight over the X-ray. So consider the force of the trauma. If this is a lower force trauma, you're probably going to begin with an X-ray. So remember, we have a number of different views to choose from, but certainly you're going to want an OM or a Waters view. You may want an OM30, a lateral view may help, OPG. Just bear in mind what injuries you're thinking about and request the appropriate images. So with the approach to the X-rays, there's a few different principles that we want to try and follow. First one, because the face is such a complex structure, there's so many different lucencies, opacities, tissues and bones overlapping, just take a careful top-down approach, starting at the top of the face, working your way down. Make sure you look at the orbits carefully. Around 60% of facial fractures do involve the orbits. You're going to trace the lines of Dolan and the McGregor-Campbell lines, which I'm going to cover in a second. And you're going to look for any asymmetry. Asymmetry is a great heuristic to hold on to, and if you can see it in an X-ray, do look more carefully because it may indicate that there's an injury somewhere in there. So on point number 3, the lines of Dolan and the McGregor-Campbell lines, these are reference points that have been essentially come up with to help us navigate the treacherous geography of facial X-rays. So the first one is the lines of Dolan. Now, these are lines of the face which have been likened to the faces of an elephant. So if we look here, this is a schematic, and we can see this is an orbit. Here's another orbit. We've got the nasal cavity, maxillary antrum or the maxillary sinus, and then the zygoma. So this would probably be something you can see in an OM or an OM30 view. And number 1 is the floor of the orbit. Number 2 is the lateral border of the zygoma. Number 3 is the maxillary antrum lateral or inferior border. And if you zoom into this, excuse the quality of the image, but you can see that this shows intact lines of Dolan and shows a zygoma and an inferior orbital floor that are intact. If you had any disruption through any of these lines, it may indicate a fracture. So learn your lines of Dolan. Next one is the McGregor-Campbell lines. And again, this is just to help us orientate ourselves around a facial X-ray. So first thing to bear in mind is the midline. If you have any deviation from this midline, just note it and see if there's anything going on there. And then you've got these 3 major lines. So the first line basically starts off at the area where the zygoma meets the frontal bone, the frontal suture, not the frontal suture, sorry, the frontal process of the zygoma where it meets the frontal bone. It's going to cross over the superior margin of the orbit all the way to the other side. Just trace that because sometimes any disruption there can indicate trauma or fracture. The second line is from the zygomatic arch all the way back here, and it's going to loop round over the zygoma, traverse through the inferior orbital margin or the superior part of the maxilla, and loop round to meet the other side. And then the third and final line is from the condyle of the mandible, going over the coronoid process of the mandible, and then through the this part of the maxilla here. And so basically, if you just follow these lines, that can help you pick up if there's any fractures. They're just lines to help you kind of navigate your way around these x-rays. Okay, so that's a bit of an introduction on the x-rays themselves. Now, let's check out the actual patterns of injury that we may see. So the first one we're going to do, as we mentioned, we're going to take a top-down approach, and we're going to start with the frontal bone here. So this bone, you can sometimes have, for example, a caved-in frontal sinus. If you watch some mixed martial arts, sometimes, rarely, someone can cave in their frontal sinus. Generally, it takes quite a lot of high energy impact to do some damage to the frontal bone, but as you know, you've got the superior margin of the orbit, and you can have a fracture through there. So start with the frontal bone. And as you can see here on this particular chap, unfortunately, he has sustained a pretty good going fracture right the way through his frontal bone here. So this is something that can certainly occur. Okay, so we've done the frontal bone. Now we're going to make our way down to the orbits. So spend a good bit of time on the orbits. Check for any rim fractures that may occur anywhere around the rim here. Just trace those lines. Trace those lines of Dolan as well. A fracture that's unique to the orbits is an orbital blowout fracture. So picture this, you're outside, you're not really having a great day, and someone throws a baseball straight at your eyeball. Once it hits the eye, you're going to get a massively increased amount of pressure acutely within the orbit. And unfortunately, the weakest wall of your orbit is the superior part of the maxilla, this bit down here. And if there's enough increase of the intraorbital pressure, that can cause a blowout fracture where you get some of the periorbital fat, tissue, and even potentially the inferior rectus muscle getting tethered through this fracture here. If you get tethering of the inferior rectus muscle, you may see something like this. Top picture shows a chap who is just asked to look straight ahead. You can already see that his left eye does look a bit funky, doesn't really look too good. The bottom picture, you've asked him to look up. Now you can see the right eye, no problem, but the left eye is unable to look up because that inferior rectus muscle here has been trapped and is unable to allow his eye to look upwards. Same thing here. Able to look upwards on the right, but unfortunately the left is just stuck looking straight ahead. So in terms of x-rays, there's something called the teardrop sign. So if we look over here, let's start with our left orbit. Everything looks good. We've got nice clear orbital margins. The maxilla looks fine here. The maxillary sinus looks good and air-filled too, no problems there. Have a look on this side, however, and we can see something here. It's a sort of increased amount of opacity just inferior to the inferior orbital margin. Now this is called the teardrop sign, and this is basically a bunch of soft tissue, periorbital fat, maybe some bone, maybe a bit of muscle poking down into the maxillary antrum. And if you see this teardrop sign, and again using our rule of asymmetry, which is very present here, then this will likely indicate an orbital blowout fracture. You can see it much more clearly on a CT scan here, where on the on our sort of right side we can see that there's a lot of soft tissue poking down through. Okay, the next thing remaining on the orbits is the eyebrow sign. So occasionally you can have air from a paranasal sinus or other area track into the orbit, and that can produce an kind of intraorbital emphysema. And the way that you can see that is to check for any increased signs of air within the orbit. Air will look much less dense than the surrounding tissue, and we can see here that that is the case. So we've got the eyebrow sign, which is this darkened area. It looks a little bit like an eyebrow. And this indicates that this person has intraorbital emphysema. It may be, for example, from a fracture through the inferior wall of the orbit, and maybe some air has tracked up through the maxillary sinus, Remember, you've got your ethmoidal sinuses here, you've got your frontal sinuses, could be from any of these really. But basically, that's not very good news. You've got air within the orbit, orbital emphysema. Okay, so we've done the frontal bone, we've done the orbits, now we're doing the nasal area. So the nasal bone, just to say, you can get a nasal fracture. You can see here's a bit of a comminuted fracture, 1, 2, maybe 3 points of fracture on this person's nasal bone. No real indication to do an X-ray if you're just suspecting a nasal bone fracture. Perhaps more important to say is that you can have septal trauma. Now, septal hematomas are something that you want to check in somebody's nose. And a septal hematoma is basically where you get an area of blood or a hematoma that forms between the nasal septum and the perichondrium. And if you cast your mind back to our anatomy lecture, the reason this can happen is because this area of the nose is so hypervascular. It's an anastomotic area called Little's area, where you've got the sphenopalatine arteries, the ethmoidal arteries, lots of different arteries, the anastomose in this area. And unfortunately, if you have a septal hematoma, that can very easily lead to things like necrosis of the septum, abscesses, infections, and this chap here actually has a bilateral septal hematoma, which can occur from blood dissecting through the septum, meaning that he's probably got septal trauma as well, so it will dissect through to the other side, and you'll have these sort of two boggy, purple-looking hematomas sticking out either side. You need to get these drained and packed. Discussion with ENT or seniors, because that needs to be sorted out as soon as possible. Okay, so we've done the frontal bone, orbits, nasal area. Now we're moving on to the midface. Midface includes the maxilla and the zygoma for our conceptual purposes. So if we're starting off with the zygoma, remember our lines of Dolan. We can actually use this skull here. Let's imagine that we get a OM30 view. So we probably go up to about here. Now we can see our lines of Dolan. It looks a little bit like an elephant's trunk down here, I guess. And we can track the lines here, across here, around here, and check if there's any fractures. And if you remember, the zygoma is sort of like a four-legged stool. The reason being is because you've got the zygomatic arch, the frontal process, the orbital floor on the lateral side, and the maxillary process here. That's indicative of, or representative rather, of the four legs of the stool. And you can have something called a tripod fracture. So the zygoma here, if you imagine that we're looking at somebody's left zygoma, you can see that there are 4 areas circled off. This is actually showing 4 fractured parts of a single zygoma. So you've got a fracture through the frontal process, the orbital floor, the maxillary process, and the zygomatic arch. And unfortunately, they also have a fluid level, which we will cover in a bit in one of their sinuses. So this results in sort of a floating zygoma. Now, if we have a look here, remember our lines of Dolan. Let's start on the left side. It's actually quite difficult to make out, I think, because we're looking at an OM30 view, which is really quite tilted back. But if we go over here, if we're trying our best to make out the zygoma here, it looks a little bit chaotic, certainly compared to this side. And if we use our McGregor-Campbell lines, you can see that actually the zygomatic arch is completely wrecked. So this one is going around nicely here, but unfortunately there's a lot of disruption to this one here, signifying a fracture of the zygomatic arch here. Furthermore, if we look at this one, it's showing us a similar thing. Now the lines of Dolan are much more clear here. Let's start on the left side and trace them. The line here looks fine. The maxillary antrum here looks fine too. The zygomatic lateral border looks good here. The zygomatic arch also looks great. How about this side? Well, not so much, unfortunately. And again, we can see that we've got fractures through here, perhaps here, and even here. So this is showing a tripod fracture. Maxillary process, orbital floor, frontal process, and the zygomatic arch have all been disrupted, showing a tripod fracture. Now, moving on from the zygoma to the maxilla and the rest of the midface. we have lefort fractures. Now, lefort was a guy who enjoyed dropping skulls out of a building to see how they smashed on the floor and how they broke. And he came up with this classification for fractures of the face. So a lefort 1 fracture is where you have a disruption of the maxilla below the nose itself, below the nasal cavity. So that would be a fracture running through this area here. And if you can imagine, if you've disrupted this entire area, the upper palate may just dissociate, and what you have is a floating palate. The next one is lefort 2, and this is very similar, but it goes a bit higher. It goes through the maxilla, up through the nasal area, and then round through the other side. So if you imagine you have a fracture line going up here, through there, and down through the other side. And now you've got dissociation of the entire maxilla. So this results in a floating maxilla. Lefort 3 fracture, if you imagine a fracture through the zygomatic arch, the frontal process of the zygoma going right the way through the skull like this. This would be a bad place to be. So up here, around there, and through the rest of the skull, around the other side. And if you imagine, if all of that is fractured off, you now have what's called a floating face. Not a good place to be. And these are usually very high trauma injuries. You're frequently going to skip X-ray and go straight to CT for these. Paranasal sinuses, also part of the face, the midface. Now, let's have a look at this side first to begin with. We've got our right side, the maxillary sinus, and thankfully it's full of air, nice and airy inside there. But using our, rule of asymmetry, if we look at the other side, what on earth is this? Well, this is a fluid level. So we've got fluid within the maxillary sinus. This may indicate either trauma, and I wonder if there's a kind of fracture through there, and that could result in blood filling the sinus, or it could even just be a really nasty case of sinusitis, where you're getting sort of pus and nastiness filling up one of the sinuses. But this is something to look out for. Check out your fluid levels, whether there are any present in any of the sinuses. Okay, so what have we done so far? We've done the frontal bone, we've done the orbits, we've done the nose, we've done the maxilla, we've done the zygoma, and that whole midface area. Now we're moving on to the mandible, this bone down here, the lower jaw. So the mandible can have 2 different types of injury. Fractures is one of the first ones. So you can have fracture through the body, the symphysis, the angle, the ramus, all these different areas basically can involve a fracture. And if we look at here, our mandibular view, it looks like we've got a fracture of the ramus up here. This looks like a really nasty fracture going all the way through, and thankfully this side is intact. But if you ask someone the question, are your teeth aligning as normal, perhaps they will answer no in this particular case. We've got our OPG view, and it looks like we've got a fracture going through the body of the mandible here, pretty nasty too. So those are fractures. You can also have dislocations. So the temporomandibular joints here is shown. This is an OPG view, and you can see here you've got the condyle of the mandible sitting very nicely within the temporomandibular joint, temporal bone up here. That may be likened to this part over here. You've got the condyle of the mandible sitting in the temporomandibular joint. Perhaps this is even better over here. So, as you saw over here, the temporal bone has the mandible sitting within it. This is on the right side of the X-ray. If we move over here, it should be sitting in there, but lo and behold, it's sitting over here. This means we have a dislocation of the mandible. This is bilateral dislocation. And just to illustrate the point, the mandible condyle can dislocate forwards, resulting in an anterior dislocation shown here. Should be sitting in there, but unfortunately it's gone straight through to there. This can result in a bit of an underbite sticking forwards, or you can have a posterior dislocation where the condyle dislocates backwards. You can even have a superior dislocation in some cases where this condyle ends up somewhere over here. Now, just briefly for your own self to look up, some of the methods of reduction include the syringe method, intraoral method, and the extraoral method. Look those up yourself just to get familiar with those. Right, so those are the main patterns of injury that are frequently present in facial trauma. So let's go and just finish off a bit about the X-rays. So to summarize with our x-rays, we're going to look for signs of fractures. 1. Look for symmetries or asymmetries. 2. Look for cortical defects, any disruption in the nice cortical lines that you'll see, for example, in those lines of Dolan or in the McGregor-Campbell lines. 3. Any eyebrow sign associated with orbital trauma may indicate periorbital air or emphysema within the orbit. 4. Teardrop sign may indicate a blowout fracture. 4. Any fluid level within any of the paranasal sinuses may also be indicative of a traumatic injury or a fracture. And then just to remember, your lines of Dolan and your McGregor lines are the reference points that you can use to discern many of these signs that you can see. So to summarize x-rays, let's just do this one together. So what I want you to do is just pause this and basically analyze this x-ray, use your lines of Dolan, your McGregor-Campbell lines, and see if you can spot anything nasty. All right, so I'm assuming that you've tried to do that. So let's start off with our lines of Dolan. Let's trace around here. This orbit looks fine to me. We've got the lines here, they all look very intact. We've got the nice trunk of the elephant coming down. The maxillary antrum looks fine too. How about on this side? Well, that looks a bit suspect there. If we trace down here, that looks extremely unfortunate as well there. Also, not much continuation here, so we've got at the very least a zygomatic arch fracture. And then going around here, looks like we've also got a fracture of the, what would that be? The orbital floor. And carrying on with this tracing of our lines, we'll do our McGregor-Campbell lines. So starting over here with the frontal process of the maxilla, tracing over. Yep, you can see that looks nice, but we've still got that nasty step off there. If we start from over here with the zygomatic arch, of course, we've already discerned that there's a fracture there. We're going to trace it over here, and it clearly looks very different to the other side, so that's not very good. And then we're looking from the condyle of the mandible around here with our third McGregor-Campbell line, tracing it through over here. I can't really make out anything hugely worrying around there. So I think what I'll settle on with this is we've probably got a tripod fracture potentially of the right zygoma and a cheeky fluid level within this maxillary sinus. So this could be blood filling the maxillary sinus. Okay, so now just to wrap things up. Conclusion. With your approach, remember those specific questions that you want to ask anyone presenting with facial trauma. Remember your exam. You're going to do your primary survey, look, feel. You're going to do a good ocular exam, sensation and motor, and consider your tongue depressor test if you're worried about mandibular trauma. Some pearls to take away. All of these sorts of injuries usually occur as combinations, rarely just individually. Always consider intracranial or cervical injury. Use things like the nexus criteria if you need to clear the cervical spine. X-rays, utilize a top-down approach. Use your reference points very astutely and look for any signs of asymmetry. Make sure you document extremely well because some of your notes may be used in cases of criminal prosecution or litigation. And after this, I would really encourage you to go and check out the Norwich Image Interpretation course. You can do a 20-question interpretation sort of exam regarding facial anatomy on x-rays, and you can even get a little certificate for your own personal development. Just some acknowledgements over here of the sources that I've used, and I hope this was helpful. Speak to you again very soon.